Welcome everyone to Hands That Shape. My name is Allegra Burney, and I have a guest here with us, Dr. Myrtle Evans. So she is a powerhouse in the world of OT, a clinician educator and thought leader. She brings unmatched expertise in pelvic floor rehab, upper extremity recovery, chronic pain management, geriatric care, and program development. As a credentialed leader in academia, through AOTA's Academic Leadership Institute, Dr. Evans has played a key role in developing and accrediting both master's and doctoral level OT programs, helping shape the future of the profession as we know it. Dr. Evans is widely respected for her person-centered approach, clinical excellence, and commitment to preserving client dignity. On this episode, she shares insights from her decades of practice, the evolving landscape of OT, and what it truly means to lead with both skill and heart. Thank you so much, Dr. Evans, for coming and joining us and being the first guest.
Oh my goodness, the very first guest. I am honored, first of all, to be here. And thank you for giving me this opportunity to talk about the profession that I truly love. Just share some insights with you as I'm sure you will ask me many questions, but just thank you so much for giving me this opportunity. It's just a pleasure to be here.
Absolutely. So when I first thought about making this podcast, you were the very first person that I thought of to do
Oh
it to
my.
start it off because you were the director of my program, but you were the first OT that I really met that I super like connected with. And when I met you, immediately I felt seen and you embraced me in a way that felt very familiar. So I for sure was like, Dr. Evans has to be the first. So thank you so much. Thank you so much. So let's
I
get
feel the
to
same.
it. I
Yes.
wanted to break the interview into two parts. So the
Okay.
first part is your perspective and experience as an
Mhm.
OT director. And the
Okay.
second part would be your perspective and experience as an OT practitioner. So, as I mentioned earlier, you were the director of my program at
Yes.
Trinity. Whoop, whoop. And so that gives you a very unique perspective. Not everyone can say they've been an OT director. It's a little cliche, but I wanted to ask for the people that are listening and who are interested in becoming an OT, what can they do to set themselves apart from the pack? Because as we all know, it is very competitive to get into OT school. So I wanted to know if you had any insight on that, maybe like things that you've seen in the past when people have applied that have made you say, "Wow, yes, this is the person that we want in our program."
Oh, that's a very interesting question. I would first say, whatever program you're looking at, or whatever program the prospective OT is looking at, make sure you do everything that is listed by the school on their website or wherever for the prerequisites and all the
Mm-hmm.
experiences they want you to have, the number of hours in observation.
Mm-hmm.
If they ask you to write a reflection paper, write a reflection paper and follow the criteria that they have outlined for you. So do all
Okay.
the things that are required.
Yeah.
Those things that are going to set you above the pack, so to speak.
Mm.
Keep in mind, the programs are competitive, so you need to outdo your competitors, right? Just
Yep.
just think of outdoing the competitors. So if everyone else is checking the box, so to speak, and
Mm-hmm.
meeting all the criteria that's listed on the website for your application, go beyond that. If they say
Mm-hmm.
that the GPA requirement is 3.2, make sure your GPA is above that. But
Mm.
you always want to have the highest GPA as possible to get into the programs anyway, because it is very competitive. And if it comes down to deciding who's going to get in, the GPA is probably going to be one of the most significant factors that the school will use in deciding who's going to get in. So the higher your GPA, the better you are. You want
Okay.
you want the high GPAs specifically in the prerequisite courses.
Mm.
Uh, all of the courses that are listed, such as your anatomy and physiology, your statistic courses, your lifespan courses, you want to have the highest possible GPA in those courses. That shows that you are ready for the program because
Mm.
those are the basic courses that you need for the curriculum. In addition to that, you want to show that you know something about the profession, and you find that out through shadowing other OTs, not just meeting the requirements for your shadowing hours to come into the program.
Mm-hmm.
but diversify rather than just going to two or three different sites and racking up your 40 or 50 hours that are required for shadowing. Diversify those hours. Do a combination of working with adults, working with pediatrics, working in community-based organization, or in an area that is very um, specialized, such as
Okay.
hand or such as pelvic floor, which I'll talk more to you about pelvic floor later.
Okay.
But show that you have looked across the spectrum of what occupational therapy can do. Okay.
Mm.
So set yourself apart by knowing more about the profession.
I think that's really key. Oftentimes, have you ever been like trying to put something together and you're like, I can't put it together. Let me look at the instructions again. It's like, oh, I forgot to read number 3 and 4, you know? So just doing what they're asking for definitely is a tip because a lot of people probably don't. I'm assuming that you've seen some incomplete applications. Say if it's 40 hours, they've only done 20 hours or they didn't do the word count. Would you say that you've seen that before?
Well, we had systems where your application didn't get into the system if you had not done
Mm.
everything. And I'm glad that you brought that up
Mhm.
because if the school has said three references, three reference letters, the shadowing hours, when you load that into OTCAS,
Mm.
those that have not completed that, the system may kick you out. So that application probably will not get to me. All right.
Mm.
Because the OTCAS system, and not all schools will use OTCAS. A lot of
Okay.
schools do use OTCAS. So there's a way that those applications are not even looked at. So even with schools that don't use OTCAS, you have the recruiting and admission department who have already gone through the first scrub of those
Mm.
applications. So if the applications are incomplete, it's not going to make it to the OT department.
Yeah. Yeah, that makes sense. And I
Yes.
also heard you mention earlier making a high GPA is important, but especially in those prerequisites,
Yes.
especially in those prerequisites. And my story was a little bit different. I didn't come straight out of undergrad.
Mhm.
Um, I took anatomy and physiology 2 as my prerequisite, and I had taken anatomy and physiology 1 like 5 years prior. So it was a struggle, but because I knew you guys isn't as in the directors and admin for the program, we're going to be looking at my prereq grades. I busted my behind and did the best that I could do because I knew those prereq courses were going to be very important. So
Absolutely.
maybe don't feel discouraged if your GPA isn't the best for undergrad, but if you have to take those prerequisites, definitely shine and get the highest grade that you can possibly get because
Absolutely.
like you've heard Dr. Evans say she looks at them. They are something that they look at. And then also I really like what you mentioned about getting varying experiences
Mhm.
for your hours. I never thought about it that way. Like to show not only that you made the hours, but you got hours in this area, that area, this area, and that area. And that definitely could set someone apart versus someone who's just gotten their hours in one practice area. That's a really good point.
Absolutely. It shows that you broaden your perspective on what the profession has to offer.
Mm.
We are beyond just treating autism. So sometimes,
Mm.
so many times, students or prospective students come into the program and they will say, well, I want to become an OT because my brother or my sister or some other family member has autism or has some other type of intellectual delay. And
Mhm.
I saw how well the OT worked with him or with her, and I think I can do the same thing. But
Mhm.
guess what? When we send you on your clinical rotations, you're not just going to work with pediatrics.
That's
You're going to
true.
have to do physical dysfunction. You will see the
Mhm.
whole picture of what
Mhm.
occupational therapy does. So if you come into the program or apply to a program and you're tunnel vision, so to speak, because you've only
Mm.
looked at one area, that does not set you apart. But when
Mhm.
you broaden your perspective and look at multiple practice areas for occupational therapy, that sets you apart from all the others who only went to one setting or went to one practice setting. Okay.
That's very true. And that brings me to like another question I probably will ask you at the
Okay.
end, which is because I know some people who came into school with me, they were like, "Oh, I don't want to do peds at all, never, never, never peds." But then they ended up doing
Doing
peds, right?
peds.
So you can't like keep a tunnel vision because sometimes you miss out on your blessing. You know what I mean?
Yes.
So the next question I have in the area of you being an OT director, have you
Mm.
found that there are some commonalities that people have that really kind of pair with success once they're in the program? Are there certain things that people usually have that makes them do well throughout school? Have you seen any of those? Perhaps I don't know.
Yes. And it's a number of things, but the thing, one I think I want to focus on is when I'm looking at prospective students, and when I think about the student who is successful,
Mm-hmm.
and this is graduate school, not
Right.
undergraduate, okay, uh, would be the student who has consistently shown that they are curious about the learning process.
Mm-hmm.
Not just simply, this is what you do and this is how you do it. Let me check the box and I've done this, I've done this, and I've done this. But one thing to me that sets a grad student apart is understanding the why in addition to the how. Because as long as you have that attitude of why we do this,
Mm-hmm.
that sets you up to be a lifelong learner. And you will
Mm-hmm.
constantly look for ways to improve yourself in relationship to the profession, and you're constantly trying to find out how I can do more. And the reason you can do more is because I understand why I need to do more. I also think students who have a solid level of, I call it emotional intelligence, when they can think about themselves and why they want to be in the profession. And it sets those people apart from those who just want to come into the profession because it's a lucrative business. Okay. It is lucrative, but that can't be the only reason. You have to self examine and ask, what can I bring to this profession? How can I impact those that I'm going to work with? By my being a student in this program, how can I leave a mark of what
Mm-hmm.
I've done with this school? What can I bring to the table? I'm coming to this university to get an education, but what can I leave this institution? So I think about all those kind of things, which goes back to that student's character and their characteristic traits. So I also like to say students who have demonstrated that they can do the work. And where do I see that? I see that in the GPA. I see that in the science courses, in the STEM courses. Is it important to have high grades in some of the soft sciences? Absolutely. But those students who have demonstrated that they can take the STEM courses and that they can pass them on a higher level is different from the student who has to take anatomy and physiology 3 or 4 times. If you have to take anatomy and physiology 3 or 4 times and you still get a C on the last time that you took it,
Mm-hmm.
that's telling me that perhaps you're not cut out for this rigorous study that you are
Yeah,
going to have to
because it's
engage in.
rigorous once you get in, that is for sure.
Very. So when I look at, can you tolerate the academic rigor? And I know that because I look at your transcript and I can see how many times you took these courses,
Mm-hmm.
repeating certain courses over and over and over to get the higher grade. It does show one characteristic about you, that you're determined,
Yes, tenacity.
tenacity, but at the same time, I have to think about, is this student going to have to take the courses over and over and over again to meet the criteria of the university? I
Mm.
don't believe in setting any student up for failure. If
Yeah.
you have to take anatomy and physiology over 3 or 4 times, when you take anatomy within the OT program or the kinesiology courses within the program or the physical dysfunction,
Mm-hmm.
if you could not do it at the prerequisite level, I don't want to set you up for failure because you cannot repeat it that many times in the
Right.
OT program. And that's
Correct.
standard. That's most universities.
Yeah, because if I'm not mistaken, it only gets offered like once a year, right?
Yes.
Yeah,
Yes.
so you can't just
Mhm.
say, "Oh, I'm just taking next semester." Nope,
No.
it doesn't work that way. Not for the master's level. So that's good information. Yeah, I totally agree. Yeah, that's very interesting. Like your perspective is, hey, I don't want to set this person up because
Mhm.
it's time to hit the books and time to hit the books hard once you get in, and that is very, very true. Very, very true. Okay, so you were my director and teacher,
Yes.
and I was a student. So I have an idea of what I think the answer is going to be to this question.
Oh
So,
my goodness.
what
Okay.
what was your favorite class to teach and why?
All right. So, I really have two favorite classes,
Okay,
and
but what was the top one?
they're equal. I can't say the one is top because they were equal and they married each other and became
Mm,
one in my
okay,
mind. Okay.
that's fair.
So my two favorites are Foundation of Occupational Therapy and Physical Dysfunction.
Okay, you
Yes.
know what I was going to say? I thought you were going to say research methods because you burned the word PICO, the acronym PICO, into my brain.
Yep. So, so research methods was my favorite because of my background in public health.
Correct.
But
It was
since
shining.
Oh, so I'm answering your questions today from an OT perspective. However, if you were a public health practitioner, I would have most
Mhm.
definitely said research methods. But because we're talking about occupational therapy and the profession of occupational therapy, I'm keeping my answers more
Okay,
centered around the
that's
profession of
fair.
OT. Okay.
Your answer is your
So,
answer.
so in OT, my two favorite courses are physical dysfunction and foundation. And the reason why foundation is so important and my favorite because you get to introduce the student to the philosophy, the theory, and all the different practice areas. This is when you first start talking to the student about
Mm-hmm.
client centered and making your treatment plan important. It has to be important and reflective of the patient that you're working with.
Mm-hmm.
But one thing that was always able to stand out in my mind, one thing that always stood in my mind is when you introduce the various practice settings.
Mm-hmm.
Now, this goes back to the shadowing hours I was telling you about a few minutes ago. When you start talking about hospital based versus community based and private practice and
Mm-hmm.
skilled nursing facilities, when that student has done different shadowing hours, everything comes to life.
Mm-hmm.
It also comes to life for those students who only did their hours in one area because those students will say, "Oh, I didn't know OTs did that. Well, I never heard of that." So to watch a student evolve when you talk about the various practice settings, that was always interesting to me, and it was always gratifying for me to see the aha moment. I'll call it the aha
Mm-hmm.
moment on a patient. Excuse me, I'm sorry, on a student's face when they
Mm-hmm.
realize that they can do a whole lot more with an OT degree rather than just work in pediatrics or just work in hands or just work with senior citizen. When they learn of all the practice areas and all the different things that we can do as occupational therapists, it was very gratifying for me to be a part of laying that foundation so the student could see the big picture. So where does physical dysfunction come in with that?
Mm-hmm.
The physical dysfunction come in the same way because once you take the physical dysfunction class and you see all the different diseases and conditions and injuries that we treat,
Mm-hmm.
that aha moment happens again with the student. And the
Mm-hmm.
other thing that I really liked about physical dysfunction, in physical dysfunction, you learn the underlying cause as to why the patient can't perform or they've lost a level of functionality. So you learn the why
Yes.
that goes along with the how. So you have to learn the why I'm doing it. You have to learn the condition. And that's another aha moment for me because once I understand and once I can help a student to understand what the disease process was on this human body,
Mm-hmm.
now this is the residual. The person can't do these things because they have this condition which has now left them limited. When you understand why and what's wrong, it better helps you to understand how to fix it. So
Yeah.
those are my two favorites because they go to me, foundation and physical dysfunction go hand in hand.
Yeah, I agree. They do go hand in hand. And I don't know how, but on your level two, like somehow all that stuff just comes back and it really
Yes.
is the foundation and it really, really is important. So I can see as a
Yes.
director how you would really like teaching that class because you get a chance to expose your students to the very foundations, the beginning, and that has to be a really, really good feeling. So I did enjoy those two classes, by the way. I really did. And I
Okay.
did learn even more about OT that I thought I knew a lot, but I learned even more. So look
Hmm.
forward to that for those prospective students out there. You will
Okay.
continue to learn, even though you did your research and your Googles and your Chat GPTs, you will still learn even more in those classes. Okay. Okay, so that brings me back to the second part of the
Okay.
interview. So this part of the interview will be talking about you as a practitioner. Okay.
My, okay. All
Well, your
right.
OT director hat is off, and now we're talking
Okay.
about you as a practitioner. Okay.
Okay.
So I wanted to bring it back, way back to
Oh
your
my
level
goodness.
twos, to your level
Relative.
twos.
Okay.
To your level twos, because honestly, in my personal opinion, I do believe that that's where you're born. As an OT, that's where you're born, is on your level
Mhm.
two. It's like you get to the level two, you're so nervous. Oh my goodness. You're working every day. You're like, oh my gosh, I hope I do well. And it's really like a stretch and a growth period. And it's like nerve wracking, but it's exciting. And then by the time you look up at the end, you're like, I'm an OT. Like you really feel like it. But at first you're like devastated. You're like shaking in your boots every day, but you get your feet about you and you are able to like really shine and make it. So my question to you is, what were your two levels? Where were your two level twos at, and what practice areas were they in?
So actually, when I was in OT school, we did three level
Oh
twos.
wow.
Yes, we
Wow.
did. We did two 12-week rotations and one 6-week rotation.
Wow.
Uh, so I did my three rotations. One was at the Tennessee Rehabilitation Center, which
Okay.
is outside of Nashville, Tennessee. It's in the town called Smyrna, Tennessee. The
Mhm.
majority of the patients there were spinal cord injuries, so that was the
Ooh.
specialty. So I did the first 12 weeks at Tennessee Rehab. The second rotation was, and I lived in Nashville at the time.
Okay.
So Smyrna, Tennessee was probably 30, 40 miles down the road from where I
Okay,
lived.
that's not too bad.
Uh, so the second rotation, I went to Anchorage, Alaska actually went to the Providence General Hospital in Anchorage, Alaska
Wow.
for my second one. The second was physical dysfunction. The third rotation was pediatrics. It was 6 weeks in length, and I did it at the Adaptive Learning Center right outside of Atlanta. I think
Oh wow.
it might have been in the Stone Mountain area. I can't remember the exact location, but it was the Atlanta metropolitan area.
So you really did get a chance to like pick and taste and choose from a lot. So I heard you say Tennessee, Alaska, Atlanta.
Yes.
So I have to know. Well, first of all, before we get into that, the first rotation, you said spinal cords, that was a
Mhm.
specialty. So
Yes.
how was that? Like, had you ever experienced and really had conversations or been close up to people who have had spinal injuries before? How was that? Was that like a little bit of a shock for you? What was that like?
It was not a shock. So I need to give a shout out to my university. Tennessee State
Oh,
University was excellent at teaching us what we needed to know before we went out on the clinical rotation. We had done level one, and we had many guest speakers to come in. And I was in the first OT program, so when the program is first, um, I was in the first year of the program.
I was too, Dr. Evans. I
Yes, you
understand.
were. So we have something else in common.
Yes.
So, that first year, the school is trying to get everything right and make sure they expose all the students to so many different things. So I was fortunate to be in the initial class.
Mhm.
And we had gotten a lot of exposure to different conditions and settings. So there were no there were no surprising moments, I can say.
Okay, good,
I
good.
did learn a lot while I was there, which was my expectation. I wanted
Yeah.
to learn a lot, and I got what I went there to receive.
Okay.
Um, so what was your next question?
Okay, so Alaska,
Oh,
Alaska,
Alaska.
Alaska. Can do tell how did you first of all, how did you manage to get a level two rotation in Alaska? Can we talk about that? Can we deep dive into that? How did you procure that? Or is that something that the person had in their bag? What is the person called that's supposed to do your level twos
Fieldwork
ticket?
coordinator.
Yeah, did the fieldwork coordinator have that in their back pocket? Like, how did that happen? How did that come about?
I think she had it in her back pocket, so to speak. I do
Okay.
recall that we had a binder. Of course, this was long before everything was on the internet. We didn't know about this then.
Right.
Okay. I do recall her having a binder and looking through the binder of different locations.
Okay.
And I remember flipping through it, but long before I got to the binder and got to that point, I had already purposed in my heart and mind that I did not want to do my clinical rotations in the Nashville area
Mm,
for many, many reasons. I
okay.
wanted to go away and I wanted to evolve into an OT, and I didn't want all
Mm.
these distractions. And something just rested in my mind, go as far away as you can,
So that was
but
pretty
still
far.
go as far away as you can and still be on U.S. soil. And honestly,
Mm,
I wanted a rotation in Hawaii and in Alaska.
okay.
The Hawaii facility that I looked at was booked at the for the time frame that I needed, but
Mm.
Alaska was wide open, so I chose Alaska. I also chose um, the spinal cord center. So I ended up in Alaska at the Providence General Hospital, and it was my FISDIS. It was the second rotation, and it was great. It was just an absolute wonderful place to be and to learn.
Wow.
So I think you asked me something else about Alaska. What did you
Oh,
just say?
no, I just can't believe you went all the way to Alaska. That is a far way. But I'm glad that you did it, and clearly it made you into the OT that you are today. Because I'm thinking about it's probably a big cultural shift too, community wise. How they do things. Everything was different there. No.
Well, surprisingly, no.
Mm-hmm. No.
Surprisingly,
Okay.
surprisingly, no. So one thing I have learned is that people are people no matter where you go.
That's true.
Okay. And when I chose Alaska because I wanted to broaden my perspective on working with different cultures, and I knew
Mm,
so I did get that experience. So in
okay.
Tennessee, there's pretty much two perspectives, okay?
Correct.
But when I got to Alaska, there were many perspectives. And then the other
Mm,
good thing about being in Alaska, there were two military installations nearby, Elmendorf, which I believe Elmendorf is Air Force, and then
okay.
Fort Richardson was Army. And it was just something in my mind about people in the military coming from all over
Yeah.
and the opportunity to just be in the community and interact with the people who come from all around the world and who
Mm,
are stationed there. That was in my mind. It's like, okay, I get to see and do some
mhm.
different things. And then, of course, the people who were from Alaska and other people who would move to Alaska for various reasons. So culturally, I got what I went for. I
Yeah.
was exposed to all types of cultures, and it was just such a wonderful experience to do that. And one thing I've always wanted to be is to be culturally appropriate and know, learn,
Mm,
and understand
mhm.
the perspective of another person from their culture. And even though I understand that perspective, if you come into my clinic with hemiplegia, I don't care what your culture is. I want your
Okay.
hand to work again. I
Yes.
still need to know about you so that I can learn how to work with you appropriately. So I
Mhm.
wanted my clinical skills to be strong, which they were,
Mhm.
but I wanted to broaden my perspective on working with different cultures, and I got that in Anchorage. And not only that, I wanted to be in an environment where I would be assessed and graded or evaluated on my skills, my knowledge, and my potential, and not
Mm.
just some type of preconceived expectation that some people may have of you.
Yeah.
Okay.
Yeah.
I wanted to move beyond that. I just
Yeah.
wanted to be a solid therapist, and I want it to be assessed fairly
Yeah.
based on skills, knowledge, and potential. That's all I wanted. I didn't want all the other stuff that sometimes goes along with certain people becoming an OT in some
Yeah.
areas. Okay. Um, and I got everything that I needed and wanted in Anchorage, Alaska. I got it there. I was at a facility that was big on clinical excellence. I got that.
Mhm.
I was able to work in an environment where cultural humility was important and that all the clinicians were able to work with all of the patients who came into that hospital. I got that. I wanted to see how
Mhm.
clinicians worked with different cultures. And I
Yeah.
got all of that right there at Anchorage, in Anchorage at the Providence Hospital.
Yeah, it sounded like it was really like a melting pot for a lot of different people. So you got a chance to practice with lot of different people. So that's
Yes.
amazing.
Hmm.
You know, I know this was before the internet and stuff, but I saw the other day, I was on Instagram and I
Mhm.
saw this woman. She was in OT school and she
Okay.
decided to go to Europe for her level twos.
Okay.
So she was in Spain doing her level two rotations, and I was like, "Psh, like that's amazing. That's a whole different culture altogether,
Mhm.
and that has their own, perspectives and views, and just to be able to navigate that and be flex gives you gives you some experience and some skills, so when you come back
Yes.
or go somewhere else, you're just ready to go. You can just hit the ground running. It doesn't matter. So that's
Yes.
amazing. Okay, and so your last rotation in Atlanta, you
Yes.
worked with peds, right? Was there like, it was an outpatient clinic? Was it like a specific population of kids that you were working with? What was that like?
It was more like it was the name of it was Adaptive Learning Center. So it was more or less I guess you would call it a day program. It wasn't
Okay.
fully a
Mm-hmm.
school, but parents brought their children to the site each morning. They picked them up in the afternoon. So I guess you would
Okay.
call it, I don't even think it's even outpatient. It was an adaptive learning center, and
Yeah,
all
it
of the
sounds like
students.
it wasn't an outpatient. It was sounded like
Yeah,
it was like a program,
it
like
was
a
a program.
therapeutic program,
Yes, it
therapeutic
was
day
therapeutic
program.
program. Yeah,
Mm-hmm.
OT, PT, and speech were there, and I can't remember. Gosh, that was in 1993,
Okay.
30 some odd years ago. So uh, I do recall OT, PT, and speech being there, and I'm certain there were other disciplines there as well.
Yeah.
But it was
Yeah.
a adaptive learning facility.
So from that experience, were you like, yes, I want to work with kids, or no, I don't
Mhm.
want to work with kids?
Yes, I was determined I was going to work with kids, and
Oh,
I
wow.
wanted to work with the autistic child,
Okay.
and I just loved it. And wow, I went back to Nashville after graduation, took a job with an entity in Nashville. We'll just say it that way.
Okay.
I
Okay.
took a
Okay.
job with someone there in Nashville, and they promised me that I would be working with autistic children in the school system, and
Okay.
it didn't happen. Instead, I was working with children who had cerebral palsy, who were severely involved, and it became emotionally draining.
Mm-hmm.
Um, didn't get the autistic children that they promised me.
Right.
It just didn't happen. And when I kept asking, they reassigned me and gave me one school, but I would only go to that one school 1 day a week. Uh,
Wow.
the other days of the week, I was dealing with the kids who had a lot of issues, and it became emotionally draining because I had too many grandparents who would pick up the
Mm.
children and they would say, "Oh, you're the OT. You're the one who's going to get Johnny to um, operate this switch or to do this."
Mm-hmm.
And my mind is not there. My mind
Yeah.
is on the child with autism and the
Mm.
population I was with, and it was just too draining. And
Yeah.
listening to parents and grandparents, that heartbreak or that inner self that says, I want so much more for my
Yeah.
grandchild. And I'm thinking, I don't think I can deliver that.
Mm-hmm.
I just couldn't. That
Yeah.
I could not promise a family that I had a magic wand, which I did not have, and that I was
Correct.
going to make Johnny whole, so to speak. And it became too much, and I decided I'm out of here. And the next thing I knew, I ended up with geriatrics, and boy, did I find out I love geriatrics. You
Yeah.
put me in the room with some senior citizens, and it's like, oh, life has just gotten real for me.
Yes.
Put me in the room with these senior citizens, and man, I loved it. And of the senior citizens, the
Yeah.
ones who had dementia and Alzheimer's, oh my God,
The
I
best,
love.
right?
That's my population. That is
Yeah.
my population.
Yeah,
I,
that's what I thought, and so I was surprised when you said peds and that you really wanted to do peds. So I didn't know
Mhm.
that. Like, this is why stories are so important. So, like I said, you can have your mind set on one thing, but really your
Mhm.
calling could be another thing. So it's
Calling
important
was
that you
another.
stay
Absolutely.
open and flex. That's funny. That's funny. I will say for me personally, I wanted to work with peds and I did
Mhm.
work with peds, but then once I got into the school system, I was like, Johnny really doesn't need my help. Like, I need to go to a different school in the
Yeah.
school system because this is not enough. Like,
Right.
they don't
Right.
really need. So I was able to finally work with a school that had a self-contained classroom, and I really love it. But I also love working with the geriatric population. I think
Mhm.
it's because at the bare bones of things, like I'm a people person, so I could just work with anyone, honestly. But no, I do feel you in terms of wanting a certain population and saying, you know what, this is not, it's not working. It's not
Hmm.
working.
It's not
And
working for me.
luckily, as an OT, we never have a shortage of jobs. So you
I
do
know.
have that flexibility.
Isn't it
You
wonderful?
can pivot at
Hmm.
any moment. So that's beautiful. Thank you for
Yes.
sharing that. I didn't know that.
Sure.
Okay, so we talked about you as a director. We talked about some of your level two rotations. Well, three of them.
Yes.
I didn't know that. And so I just wanted to ask you, like, what are you doing now as an OT? Like, what are your passions now? What's kind of exciting you right now?
Okay. Wow. That's a great question because you know me, I always have two or three things that I'm excited about. But I think um, I'll just tell you more about what I'm doing at the time.
Okay.
So I have established my outpatient private practice, and we of course I provide comprehensive OT, meaning we treat all the conditions that we're known to treat. But I specialize in pelvic floor rehabilitation, and that was born from many years of practice. And in OT, when we address ADLs, toileting, we tended to focus more on adaptive equipment,
Hmm.
undergarments, ADL transfers on and off the toilet, but it wasn't a lot of emphasis in conversation on why does this person have urinary incontinence, which takes me back to
Mm.
what I was telling you earlier.
Yes, I was
I
going to say
want
that
to
takes you back to the why, being a
do
curious lifelong learner. The why.
exactly. It took me back to that, and I began to refine this actually when you were with me over at Trinity University, looking
Hmm.
at the curriculum and looking in the OT books, the
Hmm.
FISDIS book, and the FISDIS book really didn't address it. It talked about adaptive
Hmm.
equipment and other things. It did not address the underlying cause of
Correct.
urinary incontinence. So I began to look at it, and I want to say that was 2015, wasn't it? Yes.
Yeah.
2015. So it has taken me from 2015 to now to just keep looking at urinary incontinence and bringing
Mm.
it together. And now I can honestly say a whole lot of more OTs are now doing pelvic floor.
They are.
I didn't realize that OTs were doing so much until I began to fully pull my practice together.
Mhm.
And now I see OTs are popping up everywhere, and there are all types of
Yep.
chat groups and all
Yep.
types of social media platforms where OTs are now involved in pelvic floor rehabilitation. And
Hmm.
I actually love it because the profession is now addressing the why
Yeah.
this person has urinary incontinence.
Yeah.
And many years ago, I realized this is what we need to focus on because when you look at late night TV, if you have the TV on, every commercial is about some type of adult undergarment or
Right.
protective
That's
garment. It's
true.
like if it's that much money, and then the medication,
Mm.
Mirabitric, and you just name the
Mm.
medication. It's like if it's that much money in incontinence,
Mm.
why put somebody on a medication? Not saying that now, if a person needs it, of course they absolutely
Yeah.
need it. Okay,
Yeah.
um, but let's look at why you have incontinence. And once we figure out why you have it, what can we do to address the underlying cause of your problem?
Yeah.
And that's where I am. So that's what I'm doing in my private practice is addressing urinary incontinence. And I'm starting with women, pelvic floor rehabilitation for women. Hopefully in a year or two, I'll be able to expand the practice and offer services to male patients, but
Okay.
that's down the road. For right now, my focus is urinary incontinence in women.
Okay. And I just want to take a moment to say congratulations. Big clap for you
I
having
think,
your own practice. That's
thank you.
amazing. A
Thank
lot
you.
of people dream about it and say, oh, that would be nice and yada, yada, yada. But it really, really takes a lot of work. So big
Yes.
props to you for actually doing it. That's
Thank you.
amazing.
Thank you.
Hopefully, I can follow in your footsteps one day.
You will, I'm sure.
Yes, hopefully I can follow in your footsteps. But you're right. I do feel like there has definitely been like an uptick in terms of OTs going into pelvic floor therapy for sure. I've seen that as well. So that's funny. You and I are seeing the same things. And to your point, it's like there's so much money being thrown at like after you have, pelvic floor issues
Mhm.
instead of like throwing the money before, like what's the preventative care, like what can you do ahead of time? But hey, what
Exactly.
that's the medical model, honestly, like let's be real. But good for you for being like a champion and saying no, let's try to cut this off at the pass, let's try
Yes.
to, avoid all of the gadgets and the gadgets and medication. Like a person doesn't have to do that. So if you want to plug your business now and say the name of it, you're welcome to do
Okay.
so.
The name of my company is Outcome Therapy, Rehab, and Educational Solutions. I'm located at 1300 Mercantile Lane, Suite 129-22 in Largo, Maryland. And we specialize in pelvic floor rehabilitation for women. And I want to say this much: urinary incontinence doesn't just start when you become middle age or older, it starts at childbearing age.
Yeah.
So, to all of the young women out there who are childbearing age, if you had a baby, you need pelvic floor rehab, because if you do not strengthen the pelvic floor, over time, it will become weaker and weaker. And especially if you have multiple babies, you're going to see more
Hmm.
of a problem down the road. So when you have that first baby, you need to come see me.
I
But
agree.
we need to start rehabilitating the pelvic floor in the early stages, rather than trying to fix it when you're in your middle age or senior years.
Yeah, I agree. First of all, I want to say I love how you were ready with not only the name, but the address down to the zip code. You were
Yes.
ready. Dr. Evans was like, "This is where I'm at." But no, I do agree with you in terms of getting the pelvic floor therapy. And like, it's amazing to me when I like talk to some mom friends that I have, and they're like on baby number 3 or 4. And I'm like, "Hey, have you ever done pelvic floor therapy?" And they were like, "No." And
Yeah.
I'm like, "What?" Like, no, ma'am. As soon as your deductible is met,
Oh, you're
I'm gonna
funny. You
need
said
you to
deductible.
go. I'm gonna need you to go straight there. And matter of fact, to your point, you shouldn't have to wait until your deductible is met. If it's a need, you need to go
You need
like
to go.
immediately, because
Hmm.
it's not gonna get better on its own.
No.
I feel like when you are pregnant and you're carrying a child, like your mind body association with your pelvic floor is broken, because all your pelvic floor is doing is holding on, right? And so
Did you
after
say
the
broken?
baby, no, it's just holding on. It's just doing
Yes.
the best it can to keep everything in, right? And then after you have the baby, you're worried about the baby. And then,
Yes.
it's just a downhill. So it's always good to go get things checked out, especially if you're having multiple kids, but even after one kid.
After
Multiple
one
kids,
kid. One
even
kid.
after one, yes.
And it doesn't matter whether you have had a cesarean or if you had a vaginal birth.
Hmm. Hmm.
There's still your pelvic floor is still compromised.
Yep, it is because you're holding that baby for so long. Unless you had a surrogate. If you didn't have a surrogate,
Oh my goodness! Did you say you said surrogate? Yes, you
if you
did.
had a surrogate, you don't have to worry about pelvic floor. But no, no, no. In all seriousness, I do feel like it should be something that's more regular and routine in
Hmm.
terms of women's health and women's care. Like, I
Yes.
do feel like that should be a question from your doctor after you've had a baby, your doctor or your OBGYN. I feel
Hmm.
like all OBGYN should have someone like you on speed dial, because it's very important, very, very important.
So to all the OBGYN doctors who are listening, I want to say
Yes.
to them, please take heed to what Miss Burney just said, that I
Mhm.
should be on your speed dial.
Speed dial, the
Speed dial.
favorites,
Yes.
favorite contact for sure.
Yes.
100%. So, because opening up your practice is such it's a thing, it's a feat, it's an accomplishment. I want to know, as a prospective, possibly potential a business owner with my own practice,
Well,
what surprises have you encountered that you did not even anticipate at all? Like, what are some things, and it doesn't have to be anything big or serious, but what things have you encountered that you were like, oh, wait, yeah.
yes, I would say the greatest surprise has been the length of time that it takes to get your credentials done. And the credentialing process is getting approved by the various insurance companies so that you can be reimbursed. A lot of people say go private pay or self pay. No, that doesn't work. It does not work.
Mm.
I live in PG County. My practice is in PG County.
Hmm.
People in PG County can afford it, but not everybody. And
Yeah,
most people want their insurance to pay for the
of course.
services.
We're
So
paying
back,
this thing every month. Why can't I use this?
yes. So backing it up to the credentialing process, the length of time that it takes to get the paperwork done, to get
Mm.
approved, and then there's some processes. For instance, once you get approved by Medicare, Medicaid,
Mhm.
Medicare particularly, then the private insurances will look at your application, but you can't
Mm.
even get those done until after you have done Medicare. So
Wow, I
it's
didn't know
just
that.
yes, yeah. So when you work with when you and this is oh, so the other surprise is it's not something that you want to do or even should even think about doing yourself because it is such a
Mm.
process. When you stop and think about other people go to school to learn how to do medical billing. People
That's
go to
true.
school to learn how to do credentialing, getting the credentialing processes done for practitioners such as myself, physicians, anyone who has a medical license going to apply to the insurance company so they can be reimbursed.
Mhm.
There are people who are skilled experts in getting a credentialing process done.
Mm.
That was a surprise for me because I thought, oh, I can just go to Blue Cross Blue Shield's website, tell them I want to be a provider, and I can send it. No, 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 it didn't work that way.
Wow.
So I actually had to outsource
Mm.
with a different company to get my credentialing done. Now, there
Oh.
may be some people out there who can do it themselves. I went to school to become a therapist and a public health practitioner and a public health researcher. I did not go to
Right.
school to learn the billing process or to learn the credentialing
Yeah.
process. So that was a surprise to me that, how specific those steps are to
Mm.
getting your practice up and running.
Wow.
Yes,
Yeah. I didn't think about that. Yeah, I guess that is a process. It's not
yes.
like starting a YouTube page
No.
or yeah, it's a thing. And I can only imagine, did you have a lot of communication back and forth with the people who were doing your credentialing?
Well, yes, and I'm still in touch with so you don't ever lose your credentialing team because there's something
Wow.
always happening within the insurance companies. There
Mm.
might be some changes. So you want someone to focus on that and keep you fully aware of what's going on. I meet with my credentialing and billing team on a regular basis.
Wow.
Yes.
Because in my head, I'm thinking, oh, once you get it, then
Yeah.
you're good. But you have to meet, that's news
Yes.
to me.
Yes.
Huh.
Um, and it's always something to do. I have multiple insurance companies that I take now, and you have to recertify or test ever so many days, depending on which company it is.
Mhm.
You have to log into your account ever so many days,
Mm.
whether you have a patient with that particular insurance or not. There's
Wow.
an ongoing process that has to be done. Well, I'm focused on treatment. I can't
Yeah.
do treatment and billing and credentialing. Someone else has to
Interesting.
take care of all of that for me. So it's a
Wow.
process.
Well, thank you for sharing that little tidbit and
Sure.
giving me like a little quick snapshot of like what it's like
Mhm.
to be a practitioner with your own practice and getting the reimbursements. And big ups to you for like being purposeful about getting credentialing for multiple insurances. Because how many times have we tried to go get, care from one place or another and like, oh, we only take these two insurances. So
Yeah.
that's very disappointing. So thank you for taking the time and making sure you get all that credentialing. It
Yes.
sounds like a headache, but I know your patients are thankful for that.
Yes.
And just to kind of round everything out on
Mhm.
my podcast, I want to make sure I ask this question because
Oh
I
my.
love stories and I
Yes.
feel like this is a great space to share a story. So I want to ask you,
Mhm.
what was your most memorable patient that you've had and why? And it could be from any time in your career or, any time at all from your private practice, your current practice, whatever. Let me know, what is your most memorable patient and why?
Okay. Um, I can honestly say my most memorable patient was a patient I had in Anchorage, Alaska. And
Mm,
the reason he was my most memorable patient is because of something that I experienced while I was taking gross anatomy at Meharry Medical College.
See, guys, it comes back to you. I told you, it comes
It,
back. The
it comes
books
back.
come back on those level twos.
It comes back. So when I took gross anatomy at Meharry, my gross anatomy teacher was Dr. Jackson.
Mm,
And he was explaining and teaching and talking to us, and he had a tendency to dramatize some of the things that would happen to the human body.
okay.
And I recall the day that we were having the lecture on the diaphragm, and he described or taught us the relationship of the phrenic nerve and the diaphragm. Of course, the diaphragm is fed from the phrenic nerve. If the phrenic nerve fails, is traumatized or severed, the diaphragm will not be able to move. The person
Mm,
will not be able to breathe. or the person would have some difficult breathing if it was some trauma to it. And in his description of how the patient would present who had a problem with the diaphragm, he talked in a certain tone. And I recall distinctively sitting in the lab thinking, is he doing this, OT, and all the thoughts that run through your mind sometimes, like, I'm not going to be doing that as an OT, why is he doing this, so I had that 101 thoughts that was running through my mind, but for some reason, I paid attention and I got it. Fast forward, finished OT school, finished my first rotation in Smyrna, Tennessee, and I'm all the way up in Anchorage, Alaska. Had a patient who had been involved in a horrific automobile accident. I read his chart, and I read in there the damage and the issues with his diaphragm. Just read it. I just did a thorough chart review. Walked into his room, and I spoke to him, and I gave him my name, and I said to him, "What is your name?" And I'm just going to use the name John Doe. He looked at me. He said, and the moment he said his name and started talking, I saw the teacher in gross anatomy. The student, excuse me, I keep calling them students. The patient was having difficulty breathing, which compromised his ability to talk because of the diaphragm and the diaphragm having to move so that you can breathe. So his breathing was compromised. But the moment he began to talk and he said his name, Dr. Jackson's picture, just his face just went across. I could see him so clearly in that gross anatomy lab and in the lecture hall speaking that day. And I thought, there it is. And from that moment on, I kept trying to bring what I had learned in the classroom, whether it's an OT school or a prerequisite, how did it come back to me? And I'm here to tell you that gross anatomy came back full circle while I was in Anchorage, Alaska, dealing with that one patient. He has stood out after all these years. Has been my favorite person to think back on and how the learning process all came full circle.
That's amazing. That is
Yes.
amazing. And that is a testament to how important both the books and your rotations are.
Yes.
But like good on the teacher for like being you thought he was being dramatic, but I guess he wasn't.
No, he was an excellent teacher. I mean, he was just an excellent teacher, period.
He had it spot on. So when you saw it in real life, you knew
Mhm.
exactly what was going on. That's so
Yeah.
great. It's so great to like walk in a room and feel prepared and know you know what's going on as a
Mhm.
practitioner. Yeah.
Yes.
Well, thank you so much, Dr. Evans, for
You're
joining
welcome.
us and taking the time to share your story and your
Absolutely.
experience and letting me ask you a million and one questions.
Not a
I
problem.
know that someone's going to benefit from hearing what we spoke about today, and I'm so grateful that you took the time to share your story with me.
Absolutely.
So, thank you for being the first guest.
Oh, I'm honored to be a guest, but even more so to know that I'm your first guest.
Number
Thank
one,
you.
guys, number one.
Well, thank you. Thank you very much, Allegra. It's an honor to be here, and it's also an honor to be able to help you with this new journey that you're on. So, if
Thank
there's
you.
anything else I can do to help you with this process, by all means, reach out to me.
Oh, listen, I'll come up with something. But
Yes,
no,
sir.
thank you so much for being the first guest on Hands That Shape, and we will see you next time. Thank you
Thank you.
guys for listening.
Absolutely. You have a good evening.
You too.
Okay.